and I'm very pleased to be here. This is my first visit to Vietnam, and actually yesterday I visited several places and very good. I'm very sorry, the only 20 minutes, so I speak rapidly. But my talk is TMS. Maybe you already know, but the TMS is a kind of, as the Professor Dunn said, new or old. And actually, the TMS may be old in some country and maybe new in some other countries. And so today's my talk is a intermediate oldness method of the TMS. And I would like to show the several, or just the introduction and the clinical application for central nervous system and also the peripheral nervous system. And I would like to stress that in addition to the TNER talk, most proximal part of motor nerve can be studied TMS very easily. No need just single response. It can show something which cannot be detected by F-wave. So, and central or motor conduction is not so widely used in the world. So first, this is a Dragon Bridge. You may know that is a very good place here. And the cortical stimulation. First, maybe, so the usual nerve conduction studies activate axons of two sides and conduction velocity something, and also the repetitive stimulation. And the only synapses here, neuromuscular junction. However, stimulation of the motor cortex is like this way. It is corticospinal tract made monosynaptically connected to the spinal motor neuron and neuromuscular junction. And stimulation of TMS is not only directly here, maybe some interneurons in the motor cortex. So the response and stimulation site may be included two or more synapses. That makes some difference between the nerve conduction studies and TMS MEP. So please remember this part. And so the multiple descending body, even the single stimulation here, several descending comes down here, and that activates motor neurons. And finally, we record it here. So that multiple descending body makes some difference between the peripheral nerve stimulation and TMS. And that is recorded in the spinal cord, even the single stimulation called the several or field descending bodies within the corticospinal tract. So that activates motor neurons. So even in the single motor unit, a PSTH shows single peak. However, the high intensity, several peaks appears. If only the EPFP summation, maybe only one peak, and distribution, normal distribution. However, this is different timings groups is due to which the descending body activates spinal motor neuron. So that happens this one. So because of that, if the relaxed stimulation, latency later and amplitude smaller as compared to active stimulation by the same intensity of TMS, shorter responses and larger responses appear. So please remember this one. And so I show that this is, so please sound, please, responsion. The first I stimulate. Here is a motor hotspot, and the active condition is like this way. You see the very large responses, and usually we record 3 times or 2 times. At this time, they 2 times, and relax, please. So these large responses, if relaxed, you see about the small responses, and 3 times we may take it. And I show the opposite direction, what happens, like this way. And the stimulation, again, the figure point, motor point is over the center of the coil. And the stimulation, one more active condition. One more. And so relax, please. Nothing? You can see it. So this is the important point, the direction and the position and also the tangential. So this is the usual figure 8 code stimulation. So be careful. And usually we use to record the CMCT, we need it to the active condition because of the latency is shorter. I'll show you later. So these 4 traces is the responses I showed before. As you see, this is the active condition is the anterior direction in the brain, and relaxed condition is here. And active condition, the wrong direction is like this one, and relaxed is no responses. So the latency, quite important point, that the good direction and the active condition is about 22 millisecond onset latency. However, even the same intensity, same direction, response, if the relaxed is about 25 milliseconds. So very longer as compared to 2 to 3 milliseconds longer as compared to the active condition. And the wrong direction is very similar to the relaxed condition of the good relaxed condition, the good direction stimulation, like here, is about 24.5 or 0.5 milliseconds. So the active condition, the wrong direction, the latency is longer. And in this case, the same intensity, the relaxed condition, no responses appeared. So if we would like to see the central motor conduction time, we need this latency, which means active condition responses with anterior directed current in the brain. We use this one for the central motor conduction study because that is the most shortest, probably the first descending latency to the spinal motor neurons. So the difference between the peripheral nerve stimulation is the many synapses. So enlargement occurs shortened by the voluntary contraction. In contrast, is the spinal motor nerve, and this is the seacoast just in front of this hotel, and so spinal motor nerve stimulation is the same as the peripheral nerve, the most proximal part of the peripheral nerve stimulation, and this work done about 30 years ago. In the same subject, the comparison between this spinal motor neuron to motor and muscle latency with the same subject in the spinal latency is like here. So always 0.6 millisecond, around 0.6 millisecond shorter as compared to motor neuron to the muscle latency, which means that some distal part of the motor axon could be activated in spinal TMS. So why this happens is very important to the whole of the bone. Bone is very resistant to the electricity. Because of that, the current, very high density of the current is onto the whole of the bone. So this is, say, the spine and spinal cord and motor root, or here is the spinal nerve. And activation site may be around here. So because of that, a bit distal as compared to spinal motor neuron innervating the muscle. So this is the whole. You see, that is the activation site. So actually, the stimulation is occurred here. So no difference between the peripheral nerve stimulation and just latency is wrong. So the same as peripheral nerve. So how about foramen magnum level stimulation? This site is a very good dragon in Danan, and very good place for the young couples, many couples here. Anyway, so foramen magnum level stimulation is like this way. Concoil is like a neck, and why this causes some in-between latency, cortical latency and spinal latency. Between these two, it is some response appears here because the stimulation like activate this one. Again, the hole is very important. Very large hole in the skull is foramen magnum. So many density come to here. So high density is come, and axon of the cortical spinal axon could be activated at this site. And so this stimulation like this way. Then, only one synapse. In this case, the synapse in addition to the neuromuscular junction, only one synapse, and this is axonal stimulation, so only single descending brain. So that is important. Because of that, if they contracted, latency no change because only single descending brain. However, amplitude is enlarged because the resting membrane potential of spinal motor neuron be activated by pre-activation. That is due to the latency no change. However, the enlargement of the ampoules occurs, and this is the example. A bit upward, so upward and an active condition, and please yasunde. So active, please. So you see there's some responses here. One more. One more. So as you see, the response latency is in between cortical latency and spinal latency. So we could stimulate between the spinal cord and cortex. This figure shows MEP responses recorded from epidemic muscle, and this is cortical stimulation, and this is brainstem or foramen magnum stimulation, and that is the spinal stimulation. And here, the shortest latency, longer latency, and this is about 20.5 millisecond, and this is 17.5 millisecond, and this is around 14 millisecond. So the usual CMCT is the latency difference between these two latencies. But if we use the foramen magnum stimulation, we divided the two parts, intracranial conduction or cortical brainstem conduction time latency difference, like this one, and calculated brainstem cervical latency is the different latency difference between these two. So this is the usual CMCT measurement for FDI muscle. So anyway, so that's another stimulation point we could do because of the only one additional synapses, enlargement and latency no change, and clinical application of these methods. I showed, for example, the 68-year-old man have hypertension and diabetes is a risk factor for cerebrovascular disease and appears hemiparalysis, and of course we consider the stroke. And 3 weeks wait is actually the neurological examination or no change, which means the power is 5. However, maybe the interest 60 or the maybe a different. However, you see the cervical foramen magnum is no difference between two sides, but the cortical latency very prolonged as compared to this side. So this suggests that something happens within here. So intracranial region cause something hemiaparalysis. However, this time is amplitude of these is not so different. So even the say the 5 millisecond, 10 millisecond rate is muscle power as usual. MMT shows no weakness in this case. So subclinical lesion could be detected with these methods. And another one is you see the three times recurrence, which means multiple sclerosis and several plaques in the brain, but no spinal cord at that time. However, we show the TMS and see in this case, of course, the intracranial this is prolonged. However, it's also prolonged, which suggests something happened in the spinal cord extracranial part, and maybe multiple lesion could be detected with the method. So another example is a 60-year-old man, rapid progressive muscle weakness, and he had an OPL here. So in this case, maybe the hyperreflexia is explained by this region and the segmental weakness, atrophy, and segmental sensory disturbance they all have. However, the CK is 500, a bit rapid progression, and actually the outpatient clinic doctor sent this patient inpatient, and I was bird at that time, and they consider something the muscle disorder together with OPL. However, this is ALS, and we show that the intracranial conduction delay, which means something happened in the cortical spine, within the skull or in the intracranial. So that support the patient has ALS. So two disorders or combination of two disorders may be detected with this method. And finally, the SCD, spinocerebellar degenerative ataxia patient with peripheral neuropathy. In that case, DTR is decreased because of peripheral neuropathy, and also weakness and Babinski cannot detect it, which means indifferent, not flexor, not extensor. In that case, we can detect there's some abnormality intracranial conduction delay, which suggests that something happened in the corticospinal tract in this patient. So the masked region of the corticospinal by peripheral problem could be unmasked by TMS. So these are for examples, and if you prudently use the TMS, we can use a very good more advanced or more information can be get. This is already published 30 years ago. Anyway, so that is the old one, but maybe the new one somewhere. And peripheral. This is Danam. I don't remember Danam Museum also. So I learned yesterday about Vietnam War or some other things. Anyway, so peripheral. What happens peripheral? Usually peripheral conduction, the cranial nerves, you know that the cortical stimulation of facial nerve, like this happens, and stimulation is cortex. And canal stimulation using round coil here is this restless appears, and peripheral, as usual, peripheral conduction. So this conduction shows the conduction here to here. And this small number of the millisecond is conduction intrafacial canal, and that can detect something, the facial palsy. But so you need stimulation here, cortex, is canal here, and usual peripheral is just out the foramen facial canal. So that it is used for facial palsy because the facial palsy occurs due to stimulation that is here, mainly occurs this part, and already reported many papers reported over this one, but I have no time to present. And finally, I showed something in the peripheral upper limb muscles, also stimulation like this way. There's several usual nerve conduction studies, and one added the spinal stimulation, and which can cause some proximal part. So this is the 50, what happens? 2 minutes. Oh, 2 minutes. Oh. Anyway, so neurological amyotrophy patient and amyotrophy and no abnormality can be detected with the peripheral nerve conduction studies. However, as you see, that's the L points and spinal point, a conduction block appears, and if the after treatment is recovered. So this is conduction block is recovered IVIG. So that is very proximal part of lesion could be detected with this method. So in addition to other conduction studies, please remember spinal TMS maybe detect some most proximal part region of the motor nerve. And number muscles, limbs. And I would like to say the caudal equina conduction time. To use a large coil, we can stimulate even the conus medullaris. And so the usual cortex stimulation and spinal stimulation like this way. But if we use the conus stimulation, we can detect the conus latency. So this is actually the caudal equina conduction. And this is corticoconus conduction time. This is really central conduction. That includes some conduction in the caudal equina. So this is many times such as the malignancy or lymphoma or cause the CECD and prolongation. One example is a CIDP patient. And so you see that this is caudal equina conduction, caudal equina stimulation, conus stimulation, or usual spinal stimulation. So the caudal equina conduction time is very prolonged, and also this is prolonged. which suggests that something happened in the peripheral, most proximal part of peripheral. And actually, this is often seen in CIDP. Many patients with CIDP are already published about 15 years ago anyway. So that proximal part could be detected with this method. So even a peripheral disorder, TMS, is useful. Please remember this point. I would like to stress today. So, so 15 years ago anyway. So please, if you're interested in, please refer this paper. And finally, maybe they're already over, just 0. So give me 2 minutes. One is, please come to Japan next year, AOCN, Age Oceanian Clinical Neurology. So WFN. So please come to here. This is neurology. And here is Ifcn collaboration session. But I am member of Ifcn. Also, I am member of Japanese. So JSN, Japanese Society collaboration, begin today in the opening ceremony. So please come to ASEAN 2024. And also, already mentioned, all previous 2 speakers is, please come to Jakarta next year. Thank you very much.
Okay.